Welcome to the annual case report, webinar, and Q&A of the Tomorrow Biostasis or Tomorrow Bio cases of 2024. As you can see, I'm here in the underground long-term storage facility at the European Biostasis Foundation in Switzerland. This is just to say briefly hi, and then I'll move to the office upstairs in a few minutes, and we will do the webinar there. Today, we'll do three big parts. First, I'll give a quick introduction for those of you who might not know us that much, what we do, how the European Biostasis Foundation and Tomorrow.bio and all these other organizations, how they work together. Second big part will be, I'll give a quick introduction of how we think about quality, what we do to continuously improve quality, and so on and so on. Then, of course, we'll walk through all the case reports, and very importantly, last but not least, you'll have ample time to ask any question that you might want to know, right? Since I already saw some of those questions coming up on Slido, and of course I'll share the link in a second again, we are going to prioritize questions about the case reports. We usually do AMAs and other types of webinars as well, where you're more than welcome to join as well and ask questions about, general questions about us. Today, we're going to focus and start with questions about the case reports themselves. And then if we have time, we're going to answer all the other questions as well. Now, without further ado, give me 1 minute and I'll be back in the office with the actual webinar. All right, here we go. And now also with good sound quality and the microphone being much, much closer to me than it was just a second ago. All right, as I said, I'm going to give a quick introduction initially about how this whole thing and how this whole thing works, how Tomorrow Bio works, what we do, and so on. Now, as I just said, we're going to do case reports today, and we're going to do Q&A. Now, today we're doing everything in English. In 2 days from now, on Wednesday, same time, we're doing the same webinar in German again. So for those of you who prefer German, feel free to join again and ask questions in German. Now, we have these multiple organizations working closely together to push the field of cryopreservation forward. Most of you, of course, know Tomorrow.bio the best. It's the organization that deals most with members and also patients. It does all the day-to-day work, it does all the contracts, it does the cryoprotection and the whole procedure, and it pushes R&D and medical development forward. And when I say R&D, it's more on the applied side of R&D. So it doesn't do basic research, more the applied things that can actually be implemented into cryopreservation practice. Then there's the European Biostasis Foundation. Right? This is the building where I am right now. This is where I just showed you the storage room in the basement underground. And this is what it does. It does long-term storage and it does R&D as well. Relatively broad, from basic science to applied R&D. Then there's the Patient Care Foundation. The Patient Care Foundation is an organization that is purely dedicated to making sure patients stay in cryopreservation, and the funds that need to be available to make sure that this can be done for 50 years or 100 years or 150 years or however long it might need to be, that those funds are well managed. And it is the legal guardian over the patients in cryostasis. It would also in the future fund potential revival scenarios and so on. And last but not least, we have an associated organization called Cryo.bio. It's one of these blockchain companies or organizations called a DAO, a decentralized autonomous organization, which is purely there to fund R&D. Fund R&D at universities, at private labs, and so on. And some of you who might follow us will see that we've already funded quite a few things. And in 2025, we'll announce a significant ramp up of additional funding. Now, going one step further, as I said, in the end, this is about a Q&A, right? So this is the link for all of you. Either scan the QR code or enter this link that you see on the bottom of the screen. If there's any questions, here you can ask questions. And not only you can ask questions, but you can also up and downvote questions. I'm not sure if you can actually downvote them, but at least you can upvote them. So later, once we come to the Q&A section of the webinar, I'll prioritize those questions that have received most of the upvotes. So ask your own questions, and upvote other questions that you feel like are interesting. Briefly, as I said, let me introduce you what we're doing at Tomorrow Bio. So, Tomorrow Bio is a cryopreservation provider with multiple teams in Europe. Europe was the continent that we started with. We're a Berlin-based company. The European Biostasis Foundation here is based close to Zurich. And then we're building local teams all over Europe to be able to cover cryopreservation patients without delay. And from late 2024, we've started to expand in a couple of states in the US as well. Now in early 2025, we will expand to all of the US. So very, very soon, all of the people who are currently in the US are very welcome to sign up with us as well. And if you're currently in either New York, in Florida, or in California, then feel free to reach out to us already now, because in each of these states, we have one cryoprotection team, like one medical team, that if something happens to you, would be right, in the same state, would be able to pick you up, do the cryoprotection procedure on site. In all of our cases, we do what is called whole body field cryoprotection. I think we're still the only organization that does that for all their patients. And then we would just, in quotation marks, simply fly you to Zurich for long-term storage. Switzerland, of course, being a very, very stable country, both economically, socially, whatever you want to look at. And then you would be in long-term storage here. To do this, we have these ambulances. These are two of our European ambulances. In fact, this is a picture taken just outside the building a while ago, where these ambulances are inside retrofitted to be pretty much mobile operating rooms to be able to do the whole cryoprotection procedure on site. This is a picture how that works. It has a full perfusion system, of course, a lot of monitoring equipment, and so on and so on. And as I just said, while other organizations are working on it, I think to the day, we're still the only organization that does whole body field cryoprotection in all cases. This is one of our teams. I'll try to join these cases as much as I can, because it's very important to really see the details to be able to improve, in quotation marks, every last movement of the team. So whenever I can, I'm part of those teams as well. This is the building that we're currently in. Has a lab, has of course the long-term care facility, long-term storage facility. You don't see it here because it's on the left behind the building, underground. Here on the front, this garage door, this is where the ambulances would come in. And then there's an operation room, and of course I'm now currently in the office and lobby area. And last but not least, of course, it has a lab to push research forward. And I'll show you pictures of that, all of that very briefly in a second. So this is the operation room. Of course, cryopreservation and perfusion can be done in here. On the right, you see a CT scanner, very important. A lot of the data I will share today, a lot of the quality data will be CT scan-based data. So one of the main quality metrics that can be done, or one of the main ways of how quality after cryopreservation can be evaluated. Lab space, as I said, of course, as everybody knows, cryopreservation is something that is being done right now, but on the other hand, it's also a very active research project, and of course, pushing research forward in that space is of extreme importance. This is where we just were, a bit of an old picture, just to tell people there. This is where long-term storage happens. These are our doors. Currently, we have immersion doors in our facility, but very soon we will have whole body ITS, intermediate temperature storage technology, coming up. It's actually being tested right now. This is one of the pictures where the door is being currently in testing, still in the US, but will be shipped to Switzerland. We always said 2025, and now it very much, in fact, looks like it's going to be 2025 in the end. To give a bit of a high-level overview of how Tomorrow Bio is set up, we have a bit north of 750 people signed up with us. We're not the largest organization yet, but we're by far the fastest growing. So by member number, I assume that we're going to be the largest in the world it's just a matter of time. It might be next year, it might be a year after. We'll see. We'll try to get it done as quick as possible, not because it's necessarily a goal in its own, but it allows us to have more medical teams and continuously improve our SST capabilities, which of course then helps everybody. Since we always release our patient numbers once a year, and this is now for the very first time the new updated patient number at the end of 2024, which is 19 patients. We went up, I think, from 4 to 19. So in 2023, end of 2023, we had 4 patients. End of 2024, we have 19, which partially is due to the fact that we took over some patients from other organizations who felt that the European Biostasis Foundation is better set up and for long-term safety and so on. So we took some over. And of course, even if we would have done 19 cryopreservations per year, which again we haven't because we took some over, even in that case, it would not have been enough to really train medical teams well, right? As everybody knows, and we repeat that all the time, cryopreservation and any type of medical intervention is really, really like an experience job, right? You need to have done it a lot of times, you need to have seen a lot of things, and of course, we want to try new things. And since you don't want to do that with patients who have signed up to stay long-term in cryopreservations, we accept a lot of training cases per year. Right? These are body donors who do not want to be cryopreserved or have no interest in it, but are willing to donate their body to medical research and education. And with that kind of framework, we do a lot of trade cases, as many as we can get per year, to improve our medical capabilities and train new team members. Now let's talk a bit about case reports. And I saw it always says care reports everywhere, but that should of course be case reports. So let's talk a bit about case reports. So case reports are the most important tool, and for those of you who have been in the webinar last year, this is very similar to what I said last year as well, for internal accountability, for external accountability, and last but not least, also for R&D progress. And at every case, and every organization should have a report, right? And a relatively comprehensive report, at least with cool-down curves and what has been done and what quality metrics have been, what do the quality metrics show and so on. We do this once a year, right? So that we always have once a year all the cases from the whole last year. We usually do it early in the year, in around January, mostly for logistics reasons. The case reports that we write are very, very focused on outcome and quality data, right? It's not so much, okay, so this is what happened before the case and so on. Like it's more so, what's the quality? And that's, as I said, like the CT scan being the most important quality metric currently that there is. As you might imagine, we're not releasing any personal identifiable information in the case reports. And sometimes we have preliminary case reports. There will be, in fact, a couple this year as well, and they always then get updated 1 year after. There was one preliminary case report in 2023 as well, and I'll show you the updated version with the final quality data today. And case reports, for us, the main question is, what can we improve? What didn't go well? What can we do to make it better? And at the end of all of our case reports, there's always a table showing these things we think did not go well and what can we do next time. And as all of you know, of course, cryopreservation cases and cryopreservations are being done pretty much under emergency circumstances, right? You might be far away from your base, it might have been a last-minute case. So naturally, I would not fault anybody if something goes wrong in these cryopreservation cases. Just things cannot go wrong multiple times, right? So call us out if you see multiple of case reports, in the next year and so on, when at the end of the case report it says something what should have been fixed last time, what already went wrong once, went wrong again. So this should not be the case. Now, since we talked about quality so much, let us talk briefly about our approach to quality. So for me, and of course, for those of you who know me, I started this organization because I was in longevity for a very long time and did not feel like this field is progressing fast enough, and I still don't think it's progressing fast enough. And then signed up for cryopreservation because I want to make damn sure that I'm, if I get cancer tomorrow, I want to be damn sure that I'd rather be cryopreserved than cremated. Because A, I really like living, and B, I'm really personally not comfortable with being dead. So it's a deep intrinsic motivation, meaning quality of cryopreservation is my absolute priority, and continuously getting better as well. Now, if you think about quality, there's always this discussion about viability and sometimes even versus structural preservation. So if push comes to shove, right, ideally, of course, the perfect preservation would have good viability and good structural preservation. But if in certain circumstances we need to somehow decide, we're going to choose structural preservation, because that's the basis, as much as we currently understand, that is absolutely necessary to make revival possible in the future. When I say absolutely, I mean there's some edge cases maybe where you could argue, but I think it should never be. It should never be. I don't know. There should not be a reason to not work on making sure that structural preservation is great. We work with a very clear priority list here, so trying to improve the things that have the most impact. Of course, sometimes there's discussions about details in what could be, in theory, maybe in the future be improved in cryopreservation practice. But again, we need to remember, currently cryopreservations are being done under emergency-like conditions, at least some of them. So from a priority standpoint, the field should really work on making those circumstances better, not necessarily. I mean, I would be always for putting research dollars into making sure that the best cryopreservation gets even better. But it's also very important to remember that we still need to improve the average cryopreservation significantly. Our primary post-preservation metric is CT scanning. So after the whole procedure is done, you scan the brain, and in some cases also the whole body. I'll talk about that a bit more in a second, with the CT. What you can see in that CT scan is if the cryoprotective agent has reached all parts of the brain, most importantly. Now, that is pretty much it's an indirect measurement that no ice crystals can have formed in those regions. So, of course, the cryoprotective agents, the highest concentrations are designed in a way so that that ice crystal formation is significant, like relevantly and deeply reduced, if not fully avoided, hopefully. So if there's no good CT scan, all the other quality metrics basically don't matter, because then there would be ice crystal formation, at least in parts, and everything else you've done is less important. So the first metric and the first step to looking at quality is CT scans. Now, since in 2023, we already had the last CT scans of the last patients we did in that year. Basically, there wasn't much to improve anymore. And as you will see today, the same has repeated pretty much in all cases this year as well. So from a CT scan metric, there isn't much to improve anymore. Of course, I'm not saying this will always be the case, right? We will also come across cases where just from a logistics standpoint, we couldn't do anything. I'll speak about that as well in a second. And they were not going to be great, but since in our average case so far CT scans looks good, we have been thinking about adding new quality metrics. And the new quality metric that we've added on is what is called ultrastructure preservation, where you basically look at the fine structure of the brain in an electron microscope to check that the cells look good, that there's no damage, that there's no micro ice crystals, that the synapses and everything looks how it's supposed to look, right? This will be a long journey. I don't imagine that next year we're going to report ultrastructure, everything is great, nothing to improve. In fact, I will never want to say nothing to improve. We will always want to improve to get better and better. Speaking briefly about responsibility, like I just said, there might be cases where we can't do anything, which is of course kind of true. So for example, someone could call us and say, you know, oh my God, the person that was a member with you has already died, like, I don't know, like 2 days ago, right? And then, yeah, this is not going to be a good preservation. So still, since that person was a member with us, it's not okay to say we don't have any responsibility here. So we've decided for us that Tomorrow Bio is going to take responsibility for everything. And let me elaborate a bit. This does not mean that you should not take responsibility and make sure you tell us if you get any medical condition that might lead to your death, or potentially might lead to your death soon. You should definitely take as much responsibility as well. When I say we take responsibility of everything, we kind of mean 2 big parts. For one thing, like we have direct responsibility, right? For example, let's say our team does something wrong. Of course, that's our responsibility, right? Let's say our equipment breaks and we don't have fallback equipment. We don't have spare parts. Of course, that's our responsibility. Now, what I mean by indirect responsibility is cases that I just mentioned. Like, someone calls us and says, the person died like 2 days ago and they were a member of you and they didn't tell you. Now, sure, it's not direct responsibility, but the indirect part is that we should have told this person more regularly that we need to, they need to make sure that their family contacts us immediately if something happens, right? We should have told them that, I don't know, tell us earlier if anything happens, right? This is not going to be a solution in all cases, but at least it stops us from always saying, nothing to do here, like not our responsibility. Someone called us too late, or they're like far away or whatever, right? If someone is far away, we should have told them that they need to move, right? And so on and so on. So we try to take the maximum possible amount of responsibility, but don't take this as a way to not take responsibility, right? Cryopreservation is still a very small field, so it's very much up to each and everybody to make sure that the end result is good. All right, speeding up a bit, quickly talking about the 3 quality metrics that we're gonna use or have used. So CT scans, as I said, relatively easy to do, easy to interpret. I just mentioned it. Good CT results are an absolute minimum requirement for everything that comes after. One heads up for the immersion vitrification cases that I'm going to show you today. For those, CT scanning has a limited interpretability and limited significance. I'll tell you more in a second why that is. Then there's this S-mix data point, standardized measurement of ischemic exposure, which is basically a measurement of how much ischemia, how much degradation has happened before, in most cases, or during the cryopreservation procedure or cryoprotection procedure. It's a good metric given a good CT scan. So it kind of estimates a bit how it looks in the fine structure. It estimates a bit how much damage there was to the connectome and so on. So far, we have not reported S-mix data in our cases. The reason for that is that S-mix measurements require good and reliable temperature data acquisition. So it needs basically a temperature curve. And in the way how cooling is done, since you cool in an ice bath, right, and you usually have temperature probes either in the nose or in the ears. In our case, we use the ears because in the nose we do cooling. Due to that, the temperature probes usually or regularly get hit by ice water. So there's a lot of case reports out there where, it does not look like these temperature probes can be correct because probably ice water hit that a bit. And in our case, we had that problem regularly as well. Basically all of 2023, we've worked on different methods of how to seal in these temperature probes so well that they're not affected by the outside water. Now we found a way, we call it safe occlusion, where we can in fact do that. So going forward, we will report S-mix data as well. And I already mentioned it, ultrastructure preservation, meaning electron microscopy, looking at the fine structure, checking how much damage there is to the connectome. This will be the next frontier. It will take a while. This is not easy, but it is absolutely crucial to do. Now, going forward, a few things that we will change with case reports going forward. So from now on, all of the CT scans we're doing are at -196. Historically, CT scans for brain preservation cases were done at negative 196. For whole body patients, this was not the case. But last year, we established a procedure how to do that with whole body patients. In fact, with the whole body, not only the brain, but we can scan the whole body. We've done it once so far, but going forward, this might also be a thing that we will add into the case reports. But we will always focus on the brain. So how the body looks from preservation quality in our case is not that important. We will focus on the brain and at least not get distracted by trying to improve the perfusion in the liver or whatever, and then somehow jeopardize brain perfusion. Electromicroscopy I already mentioned for ultrastructure preservation. Definitely a strong focus on more local capabilities to get away from this as much as possible, emergency situations. And now, of course, I mentioned it, we're expanding to the US with the goal, of course, to bring all the quality standards that we established here in Europe to the US as well. And SMICS would be, in addition, once this is fully figured out, how to do it in a reliable fashion as well. Reminding everybody briefly again, I think this QR code, let me quickly move it to the other side so that you can actually scan it. Here you go. So most importantly, of course, ask questions. So this is again the QR code. Write it down, scan it now, because then in a second I will switch over to the case reports. Now, all right, so coming to the case reports. So give me 1 second. All right, so this is the first case report. It says patient 2, which of course, for the person who pays attention, this was a case of last year. So this is one of the immersion vitrification cases. And of course, all of these case reports are going to be on our webpage, so you can check them out. This is an immersion vitrification case where we did the immersion over into last year. So at the end of 2023, it wasn't done. You see the curve here of Hounsfield units. This is at regular intervals. We do CT scans to check how much of the cryoprotective agent has diffused into the brains. And these dotted lines here are the different concentrations of cryoprotective agent that we continuously increase until the whole brain is fully immersed with the cryoprotective agent before we then cool it down to cryogenic temperatures. And then, of course, do a CT scan. So what was not available last year yet was the CT scans. So here you see the CT scan A in grayscale and then B in pseudo color. So all of the CT scans you're going to see are always in pseudo color. Pseudo color shows you how high the concentration of cryoprotective agent at a certain point is. You will always, in every report, see a curve or like a calibration gradient like this, right? Where you have basically the parts that are green, meaning those parts have gotten enough cryoprotective agent, or they have gotten the target. Then there's a yellow part where there is cryoprotective agent, but it's not the ideal amount. And then red is there's not enough cryoprotective agent, and then in the end here into the blue or dark red, this is frozen, right? This is of course what we want to absolutely avoid. Now, these numbers that you're going to see here, they're going to differ. The reason for that is that these different numbers depend on the temperature of which the CT scan was done. Now, as I said, going forward, we will scan all patients at negative 196, so in cryogenic temperatures in liquid nitrogen. In the past, there were some CT scans that were done at different temperatures, so this might differ here a bit. Now, coming back to the pseudo color, in green, you see pretty much all the brain, or like all the brain has reached, so these kind of small things here can be artifacts and thermocouples and so on. The whole brain has gotten enough cryoprotective agent to not form ice crystals during cooldown. And if you look at this in a histogram, so all of our cases are always going to have these histograms as well, where we basically look at every pixel and check what's the percentage of these pixels that have gotten enough a high enough concentration of cryoprotective agent. And here you see it's 100%, like pretty much. It's 99.9 or 99.7. This is all within the standard deviation. You see here these ranges. So all of this, there's a bit of a standard deviation. So by all intents and purposes, this is done. What's again as a heads up, in immersion vitrification cases, CT scans only means we didn't do the procedure wrong, right? It does not mean necessarily that this brain did not get damaged before it was fixed, right? So there could be a lot of ischemia before fixation, and then you fix it, and then you do the cryoprotection procedure. And the cryoprotection procedure here, everything looks good, but you just don't measure what happened before fixation. So in this case, this is a brain that last year we took over from a medical university, of course, because someone wanted to, like the family wanted to preserve that person. So in this case, the cryoprotection went well. There's no ice crystals, at least in a CT scan, but we cannot necessarily say what happened before that. Now, going forward, I'll summarize some reports that are relatively similar, and also, of course, to leave some time for question in the end. Otherwise, we're going to be here very long if we're going to go through those reports one by one with this much detail. So, patient 4 is an immersion vitrifixation case as well. This is still ongoing, so you see that you're not going to see a CT scan. You see this curve here again, but it hasn't reached the target yet. So this we will report with CT scan, we'll report in the next year case reports. So other than that, it's very similar. And you see, of course, here that this is always pending. Going forward, patient number 6, same story, immersion vitrifixation case, still ongoing, will take, this takes around a year to complete. And these we started in 2024. Now, as I said in the beginning, we took over a range of different patients from other organizations. So this is one summarized case report for all the patients that we took over from other organizations. We don't really have much quality data here, including we don't have any meaningful CT scans. The reason for that is that they've been preserved with different types of preservations, different types of cryoprotective agent, mixtures of chemical fixation and cryoprotection, and so on. Also, some straight freezes, of course, included. And for straight freezes, if you take them over from someone else, like what is there to learn? The reason why we can't do meaningful CT scan analysis here is if cryoprotective agents have been used that we don't use, the calibration curve is going to be different. So we don't know what means good or what means bad in regards to cryopreservation. Of course, we could ballpark estimate it, but that might suggest it's better than it is, or it might suggest that it's worse than it is. So due to the fact that we took them over, we just have them in storage. And it's a wide variety of different degrees of cryoprotective agent penetration, and then straight freezes as well. Going forward, case report number 14. This is another immersion vitrifixation case, very early, starting now to do the immersion. Gonna be part of the next year's case reports as well. Same story with patient 15. Immersion vitrifixation currently ongoing. We took it over while it was already in immersion, so that's why you see here that we directly started with like the higher concentration of cryoprotective agent, which normally you wouldn't do to avoid osmotic pressure and osmotic damage, but in this case it was already immersed while we took it over, or when we took it over. Going forward, for the last immersion case. Oh no, sorry, I'm wrong. So this is actually not an immersion vitrifixation case, but it's a cryoprotection of whole body field cryoprotection case which I'll go through a bit slower to just show you the logic of it, and then for the other ones, I'll just look at the quality data. So this is one of our standard case reports. What have we done? What kind of medication was done? What kind of cooling methodologies were used? What was the general surgical approach? What we perfused with, and so on. How was cool down done, and so on. Then from a temperature curve, you see that in this case, and this is exactly one of the reasons, in this case, we only have rectal temperature, because the ear temperatures are obviously wrong. Like somehow they drop very, very quickly here in the beginning, obviously wrong. It actually says here, like the ear probes were, like it's absolutely wrong. There's no way we would have been able to cool that fast. So in this case, we use rectal temperature, but all the S-mix calculations, of course, historically that have been done are based on either nose or ear temperature, which are relatively similar compared to rectal temperature, which behaves differently. So in this case, we don't have S-mix, of course. We couldn't even calculate it meaningful. We could calculate it basically on rectal temperature, but then you would need to, you cannot compare it to other cases. Going forward, we have a measurement of what is called end-tidal CO2. This is basically how well your cardiopulmonary, your CPS, your cardiopulmonary support works, right? So basically what end-tidal CO2 gives you, it gives you, when you breathe in and breathe out, it gives you the amount of CO2 that was in the exhalation at the top, that's why it's called end-tidal, of the tidal wave. Now, this should be, if I'm not mistaken, living humans are somewhere in the 30s. So, of course, in a cryopreservation case, since these people, there was probably some amount of ischemia and, of course, chest compressions and giving oxygen is not as good as the heart beating, you would not expect that to be that high, but at least you initially want to see some amount of end-tidal CO2 to be able that you actually, provide oxygen to the body. So this here initially is a curve that we don't have enough data to say this is what you would expect. And of course, it very much depends on how much ischemia there was before the patient was taken over. But at least you see here that for the range of around 20 minutes or so, you get a result. So what you do matters. And then over longer periods of time during perfusion and so on, nothing happens anymore. So this is basically a zoomed out view of this starting part here. Nothing happens because around 5 millimeters of Hg of CO2, that's around ambient background. So this doesn't, here basically nothing worked anymore, but in the beginning it did. And since, of course, in the beginning is the most important part, because there you have high temperatures, right, where the most amount of degradation happens, this is where it's most crucial. Then pressure, this is, of course, a pressure pressure curve for during perfusion. So during perfusion, you want to stay within these two red lines, right? You don't want to perfuse with too much pressure because, then you might burst the blood vessels, which of course you want to avoid. So here the pressure curve stays very stable except for two parts. This was one batch of tubing that we got that was low quality, where we had two tube breakings. Luckily, the team stopped everything quick enough, and we just replaced the tubing. Shouldn't happen. We talked to the manufacturer a lot. It must have been a bad batch or something like this. Like, hasn't happened since, but this is why these two pressure drops here to 0 happened while we were fixing the tubing. And this would have been one thing, that is also in the mitigation in the end. Then refractive index. So this is a measurement of where you take small samples from the venous side. So you put cryoprotective agent into the body, and on the other side, right, on the venous side, you get the cryoprotective agent. Once it has flown through the body, you get it out. And on that point, you measure the so-called refractive index. It's a measurement of how high is the cryoprotective agent concentration when it comes out of the body. And of course, once that has reached what is the target, then you can assume that the whole body has equalized to the amount of cryoprotective agent that you need. So this is always an important measurement. You should not stop perfusion before you reach it. It's a bit more complex in detail, but you want to hit this green line here, this green dotted line in the end. This is cool down, initially fast, then slower. The slower part is there to make sure that you don't get or reduce the amount of thermal stress as much as possible. And then, as I said, of course, very importantly, always the CT scan analysis, starting with the gradient and then looking at the CT scans. Now, this is a case where there's a very interesting part. So you see that most of the brain is very well perfused, very green, how it's supposed to be. Now, in these CT scans, there's always two parts, or like one area that does not need to be perfused well. This is this middle part here. You see here on the small, let me actually zoom in a bit. So in this part here, this is where you will always see like yellow to reddish areas in here. These are the so-called ventricles. These are fluid-filled areas in the brain that do not, there is no brain tissue in there, so there also doesn't need to be any cryopreservation, cryoprotective agent, and it usually also doesn't get there, it can't get there well. So this is totally fine. What surprised us a bit was this part here. Now, this is normally would be brain tissue. We have another scan here, I'll show it in a second. So when you analyze that in details, this is very likely in a large ventricle. There are certain conditions where ventricles can enlarge. And of course, here you only see slices, but in a 3D remodeling, you see that this is very likely a ventricle, so not filled with brain tissue either. In the CT scan analysis, you have some amount of small areas here. So the other one, the immersion vitrification case, is better. They're usually better, but it's also in the 90 to even slightly higher percentile range. As a heads up, this very much relies on also which slice you choose, right? Here we're only looking at one slice and look at all the pixels here. So we always choose the same height and the same orientation of size. So in the whole brain, these numbers might differ a bit into either direction. And let me quickly see if so all of this piece, and you will see this in a second. So these are the areas here. These are the ventricles, totally fine. What puzzled us initially were these areas here, over here, which normally would look like this is a part of the brain is not well perfused. But we have a different CT scan. So we have one scan that was done in the very beginning, before we took this. So this brain was done somewhere else, and it was put in a box and brought to us. Even though we did the whole procedure, the transport and the cool down was not done at our facility, but somewhere else. Now, this is the same area. So this area here and this area are the same. And here you see, in the original orientation, it's very likely a ventricle. We don't want to, I can't be for sure that it's a ventricle, but it's very likely a ventricle without brain tissue in there. There is one part of the brain though, and this is why we have it highlighted here, in the cerebellum, so in the back part of the brain, there is one area that is not well perfused. So in this case, it is likely a vessel that was occluded. Of course, we don't know what it can be pre-mortem, can be post-mortem, can also be technically an air embolus that was caused during perfusion. It's unclear what it is, but this part here of the brain is not well perfused. Luckily, it's in the cerebellum, where usually from a perspective of where memory is stored, where is personality stored, and so on. If there's one part of the brain, then probably the cerebellum is the least important part. So, long story short, this part is not well perfused. And at the end, as I said, you always have this part of what can we do better. And you see already here it says peristaltic pump tubing broke during priming perfusion. Definitely not something that we want to have happen again. So all the tubing was tested, we bought new tubing, and so on and so on. Hasn't happened since, so it's probably fine, but we'll still continue testing regularly. Very important, we're not only reporting, of course, what went wrong and how bad it was, but also what are we doing about it and what might we have already done. So when this is green here, we have already fixed it. right? Meaning we have changed the procedure, we've bought new equipment, we've found a workaround, and so on and so on. Some things, of course, are not crucial. Like, for example, in this case, the ambulance tank wasn't full, right? It's not supposed to happen. That's why we call it, we say, hey, it's a medium problem, but it's not technically, in this case, it was not an actual problem. So in here, we also take theoretical problems, things that we would, if the case would have went differently, would have been a problem. And of course, we want to fix it. So a lot of these things, it doesn't not mean that something actually went wrong in this case. It just means that we found a thing that needs to be improved to not potentially have problems in the next time. Last but not least, timeline, what happened when, and then going to the next report. So I'll speed up a bit looking at the time as well, even though I'm more than happy to stay longer and discuss more, but just to give more time for questions. All right, case 18, another immersion vitrification case, same story as before, process is still ongoing, so nothing really to report yet. Case 19, very similar to the case that I just showed you, the whole body field cryopreservation, cryoprotection case. Same fundamental case dynamic. I'll just point out if there's anything interesting. So in this case, the ear temperature is there and also largely reliable. Then perfusion. There's one point here in the perfusion where we don't have data collection. All the other points were collected, or this is data, but the team, based on the team notes, this is the most likely point that we predict, but it's not a measured point. And whenever there's something that is like I don't know, unique or like open for discussion, there's like a disclaimer, right? Where we might say, listen, we don't know exactly what happened here. Same here, we hit the green line, cool down curve, and of course CT scan analysis. You see a good amount of shrinking here. You didn't see that in the other cases because these were extracted brains, so of course we don't see the shrinkage anymore. Here, shrinkage in cases where you have shrinkage, you, of course, in the part that is shrunken, you don't need cryoprotective agent either. So around here, around the brain, this is not brain tissue, right? So no need for cryoprotective agent to be in here. These part here between the brain and these are ventricles, and between the hemispheres, you can see this kind of here in the grayscale. Other than that, well-perfused brain as well. Maybe quick heads up, the shrinkage is because in cryoprotection, the fluids that you use, they're hyperosmolar. So they have a high osmolality, meaning they draw out the water out of the tissue. The reason for that is because these cryoprotective agents, they cannot easily cross the blood-brain barrier. So they don't easily get into the tissue. They stay kind of in the vessel, at least partially, and then draw out the water, which helps you avoid ice crystal formation, but leads to this shrinkage, which of course you would ideally avoid as well. So going forward, once the research is done, we will add what is called a blood-brain barrier modifier, which is a component that opens the blood-brain barrier, and you need to do it in the right amount to then be able to get the cryoprotective agent into the tissue and avoid this shrinkage. Here, again, brain well perfused. The rest of the outside of the brain, it's not. Where again, it also doesn't need to be. And if you look at this in the data, here it's a bit more difficult for us to clearly separate what is brain and what is the outside. So the line that we use for this is a bit more fuzzy. So these might be slightly better or slightly worse. But we're again in this 90 percentile range of where we want to be. Since this is just a slice, right? Ideally, of course, we want to be 100%, but that's most likely partially always the reason because of the slicing. Because visually, you see the brain apart from the ventricles. These parts again are here the ventricles. The brain is well perfused. Same here and same here. For cases where we have shrinkage, we do one additional analysis, which is an amount of shrinkage analysis, basically. In this case here, it's around 36%. Like the volume, basically, how much the volume went down. Shrinkage amount. You see it here as well, but it's very small. Let me zoom in. Of course, you can see this in the PDFs that we released way better here. It's around 64% of the original size, so around 36% shrinkage. And last but not least, as always, we have the mitigation. All right, and last but not least, before we go into questions, one more case. Again, I'm only pointing out what is unique here. Ear probes. This is where we use the new technology. Going forward from this, we're quite confident that our ear probe data is reliable. And once this becomes the standard, and we've done it a few more times, we're going to go and report the SMICS data as well. End-tidal CO2, some activity here in the beginning, then going down to baseline. Pressure, same story. We are in the range where we want to be. Refractive index, hit our target, same as before. CT scan analysis, you see shrinkage again. You can see this here in the grayscale. It's a bit easier to see this, where you have here between the skull and the brain, you have this black area where the brain has basically shrunken away from the skull. And again, you see there's cryoprotective agent in there, but low concentrations and so on. This is a slightly different view, which makes the color slightly different, but generally same direction. Ventricles, again, no brain tissue in here, cryoprotective agent in there, and here around the brain, as you've seen many times now as well. And since here we have shrinkage as well, there's the analysis of the shrinkage as well. One unique thing, as you might see, we don't have the percentages here. The reason for that is that this was a case that was done by us, but it is not stored with us. So it has went to another long-term storage facility, even though we've done the whole procedure. Now, since the shipping was done at dry ice temperature, and our calibration, the detailed calibration at least, is only at negative 196. So all of our CT scans in the past, not all of them in the past, but all of them going forward, and most of them in the past, was done at negative 196. We know how to do the analysis at that clean, negative 196 Celsius temperature the best. At all the other temperatures, you always have problems to calibrate your CT scans because you don't exactly know if you measure here in the ears or in the nose, you don't exactly know if this is the perfect temperature or an indicative temperature in the brain as well. And of course, since you don't want to keep the patient too long at negative 80, right? You want to put them at negative 80 then and ship as quick as possible for further cool down. We can't wait until the patient has completely reached negative 80. So in these cases, we transported the patient to Switzerland to do the quality assurance, and then from here to long-term storage as quick as possible. But we couldn't wait until the patient has reached negative 80. So consider these CT scans indicative. We don't exactly know how to analyze these CT scans in a quantitative state. So qualitative, you can visually see it, but quantitatively, which would be the histograms, we don't know how to exactly do that. So this is why we didn't include it, because we don't want to make any wrong predictions. We have scanned one patient of us at negative 50 and negative 196. So our best assumption is that a CT scan that looks like this, which was also somewhere between, if I'm not mistaken, somewhere between Actually, I might be able to look it up. It should be in here. It was done at negative 40. So a CT scan that was done at negative 40 and looks like this looks completely green if it's at negative 196. But since we haven't done it, we can't say for sure. Right, shrinkage and mitigation in the end, and timeline. All right, this was a tour de force, and now I'm more than happy to answer questions that you might have, and again, remind you, this is the link to answer or to write questions. So since there's 48 questions right now, I'm trying to go as quick as possible. If you see questions about the cases, tell me, vote them up. You can't directly tell me, but vote them up, and then I'll prioritize those. All right, in the European Union, what are the biggest legal challenges for the cryo field? Mostly, fundamentally, the legal challenges are relatively, it's fine, right? Of course, there's some countries where we would like to have some improvements. There's some countries where there needs to be some delay between circulatory arrest and until we can take over and after death has been pronounced and so on. By and large, it is fine. If you ever come into the situation and you're in some country and you would like to, for whatever reason, you might die soon, and then reach out to us and we'll tell you if we would recommend going to another country. And hopefully by then things have already changed. By and large, it's fine. How many of your patients are whole body patients and how many are brain-only patients? So from the patients, whole body patients are currently at this facility, or from the cases that you've shown, 4 whole body patients that we've done and are stored here, and 1 whole body patients that we've done but that is stored somewhere else. So however you want to calculate, 4 or 5. Brain patients, we have taken over 11 patients from somewhere else and 4 additional ones from ourselves. So altogether 20, stored 19, and out of these stored 19, it's 4 whole body and if I'm not miscalculating, 4 and 15 brain. Are full body dry shipping containers still being worked on? Kind of. So the idea is whole body dry shipping containers means currently you should ship if you want to ship across the Atlantic from the US to Europe or from Europe to the US, you ship at minus 80 degrees about. You ship in on dry ice. Now, you don't want to stay too long at dry ice because at dry ice temperature, it's basically a temperature where you have ice crystal growth. So you don't want to stay there for too long. It's a bit complex in detail, but and a whole body dry shipping would mean you put a liquid nitrogen into a matrix, and then you can cool down a shipping box to liquid nitrogen temperatures, or at least cryogenic temperatures, and ship at that temperature. But they're very difficult to build. Currently, none exists. We have been working on it a bit. We will continue working on it a bit. But for the time being, for the people in the US, we have pretty much, we basically have an alternative solution where if we perfuse in the US, we go slightly higher in the end with the cryoprotective agent concentration. Since at that point you're already at very low temperatures, so the slight increase in concentration doesn't have any relevant or significant toxic effect, which normally you wouldn't want to do, but low temperatures, it's likely fine. And then at those temperatures you have more time to ship because now ice crystals can't form or can form only significantly slower. And of course, you get to Europe, within a day or two. So we found a way of how to not have that problem, but long term we will still we're still working on and might add whole body cryogenic temperature shipping as well. What's the name of the third-party organization you took some patients over? If they want to release it, they can. From our side, that's not a problem, but we would not release it without having their specific consent, and I'm not sure if they're open for it. But they would be totally fine to release it. How much funding would you receive if you decide to make Tomorrow Bio a traditional non-profit? Would you grow as fast? No. So Tomorrow.bio, or like the European Biostasis Foundation, started out as only non-profit. The problem, there's a tremendous amount of people out there who say, we talk to a lot of people who say, yes, I understand why it needs to be a non-profit. I'm for it. And then we ask them, okay, do you want to donate some money? And then they're like, nah, donations are not things I do. So we set up Tomorrow now in this dual structure where the long-term storage is all with the non-profit part, and the day-to-day is a company, but it has like oversight from the non-profit, so to make sure that it stays mission aligned and giving us the opportunity to act significantly faster. And I think since we're now in a field which has been around for decades and decades and hasn't done, progress has been way slower than I would have ever hoped, I think it's a good trade-off. Right, how would the immune system react in cases of tissue regeneration or transplantations of new organs after thawing? Good question. I would assume that in the future, let's say you get new organs, that then the problem of immune reaction of transplantation would be solved independent of us, right? Independently, right? Because it's a topic that is being researched, for organ transplantation. So I would assume that this is a topic that would be fixed in the future, regardless of anybody being in the cryopreservation or not. So it's not something that we actively work on. We'd rather hope or assume that this will be solved in the future. Have you started using intermediate temperature storage systems? No, we have not, but we will get, fingers crossed, our ITS doers sometime this year, and then we'll offer it as an option as well. What are the main improvements in terms of cryopreservation handling compared to the previous year? It's a long list of details. First of all, the whole analysis is better, right? Like now we know for sure that scanning at negative 196 is the way to go. It's more stable, the interpretation is better, and so on and so on. So that's definitely one big thing. Then a lot of cooling methodologies were changed, right? We cool at different points now. For example, as I said, in our case, we do the temperature probes in the ear, because we need the nasopharyngeal space for faster cooling, right? We basically flow coolant, like water and ice water, through the nasopharyngeal space, which in the back of it has a large part directly connected to the underside of the brain, right? Of course, there's a bone between it, but from a heat transfer perspective, it's a relatively thin bone. So we have these new cooling methodologies, right? We have peritoneal lavage as a cooling methodology. So it's a long, long list of small things. Apart from, of course, just being better in the procedures, having more team members trained, and so on. So I think, unfortunately, there will once be in a while will be a big thing, and then there will be a long, long list of small things that altogether are probably equally important, if not more important. Hi, I'm from Latvia. Will the standby teams be operating into the Baltic region, and how soon the perfusionist can arrive in Riga? Riga, whatever is the driving or flying distance from Berlin, of course, if we have a case there, we would position a team on site that would then be on standby to then be able to take over immediately. In general, Baltic region, maybe not all of it, but Riga would definitely be something where you can sign up with us. And if you have any questions in detail, reach out to support@Tomorrow.bio, and Will and the team are more than happy to get back to you with details. I heard about plans for a second storage location, also as backup in the future. Any news about that? So long-term, Tomorrow.bio and EBF, we plan to have many storage locations, right? Like any type of risk that you can mitigate for the long, long future, we're trying to mitigate. But all storage locations in the world could currently have more patients to be really financially, I'm not saying they're financially not stable, but it would be nicer to have more storage facilities. Now, I don't think, if someone comes around and says, hey, here's 5 million if you build a new storage facility wherever I am, okay, fair enough. We happily take our expertise here and build one and so on, but for the time being, we would not do it from our own cash, because I'd rather put my money towards improving SST procedures, have more teams, right?
it's not like storage facilities. If you're a journalist, storage facilities are the cool thing to take pictures of and visit, and now you can touch the door and so on. But for the day-to-day procedure of doing cryopreservation, storage facilities are boring, right? There's nothing, pretty much no part of either a good cryoprotection or a bad cryoprotection is decided, or like a good case or a bad case is decided at a storage facility. It's all decided in the medical teams on site and so on. So we would not focus on it for any time soon. Right. And by the way, I should mark these questions as answered, because otherwise I'm losing what I've already answered and what I haven't answered yet. Right, going forward, let's see where I was. Intermediate storage, okay. Is it possible to collaborate with euthanasia organizations, associations, Switzerland, to minimize the time for the moment of death? We would not collaborate with anybody. So if someone decides that they want to do euthanasia and then cryopreservation after, that's up to them. But we would not integrate these two parts for a lot of legal reasons, for ethical reasons, and so on. So there needs to be a strong firewall between these two things. Of course, you can be cryopreserved in any case. Once we have a death certificate, right, from whoever and however the person died and the doctor pronounced that patient, we can always do the cryopreservation procedure. But combining these two things is not currently something that we work towards. Do clients prefer to cryopreserve themselves or their family members? Are clients usually male or female? So almost everybody in our case signs up themselves. There's once in a while someone with a family member does it, but in almost every case, it's the people themselves, and it's more men than women. Is Tomorrow.bio planning to offer permanent storage? Is Tomorrow.bio planning to offer permanent storage at the Cryopark? It's in Texas. It's not technically Cryopark. I think it's the timeship property or something like that. Not specifically right now. So again, if someone comes around and says, hey, I really want a facility here, can you help me? Can you run it? Someone would help pay for it. We're always happy to collaborate and talk and so on. But again, multiple storage facilities is not how this how this field advances. Is a long-term storage as a separate service already official? I'm not sure what that means. Maybe elaborate, and I'm happy to come back to that question. The organizations, the Tomorrow.bio, which does the service, and the organizations that do long-term storage have always been separate organizations in our case. So that was always the case with us. Right. How many brain patients did you take over? We already answered that. Let me see. By the way, these questions are flipping around here a bit because people up and down vote them. So I'm getting let's see what I haven't answered yet. Funding we have answered. Main improvements we have answered. Sorry, I'm 22 years old. How to find a transhumanist girlfriend? Can't help with that. I don't know. You can sign up for yourself, and then you might not rely on family members. For all the rest, I think other people are more qualified to answer. Right, that is answered. When will you when will you be using the blood-brain barrier modifiers? It's currently an active research project, so they're still in research. We will start using them. I hope that this project ends this year, and of course, the result is, in a way that they actually should be used and can be used, and we know the concentration. The hope would be this year. How the new organization structure works. The diagram looks kind of complicated on our structure page on the web page. Yes, so it's not technically a new organizational structure. It was always like that. In the past, just the EBF was taking the role of the Patient Care Foundation, where now it's a separate organization. Cryopreservation is complex. Unfortunately, it's not as easy to explain it in a short paragraph. Because you have these different organizations for a reason. Different organizations are annoying, right? I would rather have one organization for everything, but you want to optimize for multiple things. You want to be fast on one hand, but you also want to be maximally secure on the other hand. So unfortunately, it's a necessity to have these organizations. If you have any questions, we're more than happy to discuss and help. So just reach out to us, and the team and I am happy to discuss. Are there any issues with, oh sorry, the next question would be, where are the 19 people who patients from? Do you notice a pattern where most of our members? There is no real pattern. It's all over Europe, now also the US. So it's all, like we don't have enough numbers yet to really see a pattern. Are there any issues with cryopreservation in Italy? I heard that there's a 24-hour waiting period. So Italy indeed is not an easy country. This 24-hour waiting period can be gotten around in, but it's not that easy, unfortunately. So Italy would be one of those countries where it's probably not a problem, but in certain circumstances, it can make sense to go to another country. Where the patients are from, we already answered it in another question. I believe you're planning to offer cryopreservation at slightly higher temperatures. Like since you upvote questions all the time, it's moving. So let me actually switch to recent. Hold on 1 second, because otherwise I don't have time to read the question. When will this be offered? So basically the ITS, hopefully this year. Why are most of your cases typically preserved using the immersion vitrification? Does the brain deteriorate during the months required in the process? So it's not most of them. It's half-half. The reason why this slightly leans more towards immersion vitrification is because we took over some cases from another organization, and some of them are immersion vitrification cases. The cases that we've done, most of them are vitrification cases. In the month of the cryoprotection procedure, nothing happens, so this is not an issue. So the fact is that it's an immersion vitrifixation case, so you have already done the fixation, meaning the brain is already protected, and then you do the immersion cryoprotection while you do it at 4 degrees and you have time. Let me quickly, okay, next question. I see there's no continuous measurement of perfusion pressure based on the report. Is this correct? If so, in some cases, yes. In some cases, we basically take the, so we have 2 types of pressure sensors. We have one inline pressure sensor, and we have one analog pressure sensor. We had some problems with the inline one, and then we use, but this was always the case, so we always had these two things, and then we use the manual one, and if we use the manual one, then it's not as fine. So in some cases, for example, let me see, I'm not sure which person, where it looks like the same, basically the pressure was almost the same. There might be a few millimeters Hg of difference, but since it's a manual dial, you don't see the difference. And in some cases is recorded from the cameras, so where you only have certain data points. Why was there no citrate administered in P17? Let me see quickly to that report. If there's no explanation in there, we'll add it. I'm not sure. Let me see quickly. This was a case where we had. So first of all, we took over the patient relatively late after circulatory arrest. Where all lines we did, either bone injection and the existing lines were like, it wasn't really possible to perfuse any or give any relevant amount of medication. Nothing really worked. And then at some point, we gave the kinases, heparin and propofol, even though propofol already didn't work well anymore. And to be fair, in this case, it's not super necessary anyway. And then we just continued because we didn't want to spend too much time onto it. Like we had one person continue to try, but the rest of the team moved on. And then at some point, we were already moving. That everything was moving forward. In which EU countries is compulsory autopsy for young people less of a concern? In which countries? So it really depends. I don't know if there's a country where it is less of a concern. It is always a concern if the person dies under non-natural death, for non-natural causes. I don't know if there's a certain country where it is less of a concern. Long-term storage as a separate service means you pay only for long-term storage without cryoprotection. Is this already official? We would likely not offer this. So at least not as an official thing. So if someone says, hey, someone has died already and they have been in, like, let's say, in chemical fixation, and can you take over for security? In that case, we would do it. But we would definitely not want to incentivize anybody foregoing SST. In edge cases, if someone really can't afford it and whatever, then reach out to us and we'll try to make something work. But we definitely don't want to incentivize someone just going to their next funeral director and saying, hey, can you perfuse some cryoprotective agent? And then I'm going to get stored at EBF in the end. It's a horrible idea, like highly, highly not recommended, so we would never offer this officially. And even unofficially, only in edge cases, only if there's no other way, and so on. But yeah, don't do that. You need to get SST, unfortunately. Like otherwise, the preservation quality is just far, far below anything. Are you going to get more ethically Indian patients in the coming years? I have no idea. Like I don't know where. Well, I can look it up, but I don't really care where our patients come from. Anybody is welcome. Why do you have very young members compared to other organizations? To my knowledge, it's not actually that we have young members. Also at other organizations, that people who sign up, they're usually relatively young. Just because the other organizations have been around for longer, those patients or those members have grown old. So at sign up, I think there's not much a difference. Just since we grow significantly faster, way more members sign up per year. So, and since we haven't around for that many years for these people to grow old, that's why it looks like our average is younger, which of course it is because of that. When will biopsy consent contracts be sent out? So it will be added to the new contracts, and we will reach out to everybody probably within the next 2 or 3 months. The question is about, so to check the ultrastructure preservation, we need to take a very small, a micro sample from the brain, right? We might take it if you give consent, of course, it's up to you. Like you can give consent, or you can say I don't want this, but it will be in the contract, and then you can say no, I don't want this. For everybody who signed up in the past, it was not in the contract, but if someone is fine with it, then they can give consent, and then we can do this more advanced quality metric. And you can potentially, and we're currently working on it, also take a sample from the spinal cord, where again, this is far away from any part where there's at least as much as we understand memories or identity and so on. It would be the same procedure as you also currently do in neurosurgery operations. What do you exactly mean by saying you took over the patients from other organizations? Does this mean the living members switched over to? No, so there's another organization that had the right to give the patients the patients in storage to other organizations, other research organizations, of course, not to anybody, for long-term storage. And in those cases, we took over because we were deemed to be more long-term stable and secure. Do you consider this to be transhumanist as the protocol of Brian Johnson is? So I try to stay away from any labels. So no, I would not. I just consider cryopreservation as cryopreservation. So not as any part of any larger story or anything. Cryonics Germany, as they said, had 50 brains, but you received only 10 for them. I can't speak for any other organizations. You would need to talk to them. Approximately how many patients who donate their bodies for medical research do you receive per year? Way too little. So we try to go to 20, and ideally even more. Which some years we can make it there, some years we don't. It could be more, but we're actively trying to get new collaborations to be able to do so. In P20, why is there 50-minute between the patient stabilization process and surgery? Because in that case, for like a variety of adhesions and surgical complications, it took so long. Not happy about it, but it took so long. How was the patient transfer funded? Basically, we got the funding for the long-term storage amount. Like EBF basically has a certain amount of, and more precisely, the Patient Care Foundation has an amount that it needs for long-term storage, and that these funds were provided. Are you linked with political associations that support transhumanist issues? Nope. In fact, as a foundation, we're staying away from anything political, including that we cannot get involved in anything political. So no. Will you provide country-specific guidance on how to set up last wills? Do you resuscitate orders, advanced patient directives, and other legal documents? No, not country-specific. We have a base, like a base template that, to our understanding, works in all European countries and the US as well. But we would always advise, at least not right now. Down the line, we might have different contracts that have been checked by all lawyers from all countries. For complexity issues for right now, we're not aware that there's any problem, but if you want to have 100% certainty, you would need to talk to a lawyer in your country. Is it currently possible to give the patient care fund money to manage while the patient is cryopreserved? Yes, it is. Maybe you mean as a donation, maybe, but reach out. In most cases, this will work. What are currently response capability times for the UK? Are there plans to develop a UK-based resource? Yes, so the UK, currently, UK, of course, has a very strong, or like comparatively, at least to other countries, has strong local teams with Cryonics UK. So if that's the case, we would be more than happy to collaborate, which, by the way, is a general statement for any organizations. Of course, we've talked to them in the past. Otherwise, our main method of SST is we send the teams, right? So we would send the team to the UK as well. But if there's local teams, we're always more than happy to collaborate and, of course, and to pay all costs and so on. Down the line, there's definitely, for every country in Europe, we plan to have local teams, either volunteers or our own, initially volunteers, then our own, including ambulances. So this topic of more local capabilities will definitely be a significant focus this year and next year's. Tomorrow, there will be longevity investors lunch in Davos. Are there new fundings for Tomorrow.bio? I'll attend the WEF meeting in Davos at the same time. Well, maybe we can meet there, because I'll be there at exactly that longevity investors lunch and talk about what we do at Cryo.bio and Hydra.bio regarding cryopreservation. So maybe we'll see each other there. And Tomorrow.bio has always some funding rounds open. So if you're interested in that, also I'm more than happy to talk. I saw propofol. Can you tell us why you need this? So under certain circumstances, it is possible that patients are being taken over very shortly after circulatory arrest. This is not so much, unfortunately, a topic in Europe, because in Europe there's always a significant or relevant delay of, like, let's say, 15, 20 minutes between circulatory arrest and we taking over. But since we start with very aggressive CPR, we give propofol that if in the case you would take someone over very, very quickly after death, and of course they're pronounced dead, that you would not have any problems with potentially spontaneous activity of the heart and so on. And the second thing, it's a neuroprotective. So propofol also helps just with the procedure in itself. Is it compatible with religious belief? Isn't it a major blocking for the business model? So first of all, we're not primarily doing this as a business, right? It's a more mission-driven company. The religious beliefs, I mean, this really depends on the personal, what people personally believe. Of course, most people who sign up with us are on the agnostic or atheist side. But we also have people who are religious who say, if I'm cryopreserved, I have more time to do good for God and so on. And of course, I can't say, I don't really have an opinion either way. Why people sign up or why they don't sign up. But statistically speaking, it's more agnostic and atheist people by a large margin. How do you decide in case of doubt between structural and preservation and viability? We would always decide for structural preservation, meaning, for example, in one case would be that under certain circumstances we switch over to immersion vitrification, where you basically have a chemical fixative, which of course would reduces viability to 0, right? But it protects structural preservation. So that would be one example. Where can I download the case reports? You find them on our webpage, Tomorrow.bio, under documents, and then there's case reports. From which country are the patients from? How many from Germany? How many from Spain? Off the top of my head, I don't know, but on our webpage, I think it should say. Are immersion vitrification cases roughly as good as usual cases regarding CT results? So it's very difficult to compare them directly. So the CT's results of immersion vitrification cases, they look good because by the procedure, you check with a CT scan of how much of the cryoprotective agent has already diffused, right? And you stop the procedure once it has completely perfused. So from an ultrastructural preservation standpoint, since the immersion vitrification case, at least in our case, we do it if there's a lot of ischemia, they are probably more towards not as good, whereas from a CT scan perspective, they are by definition good. So in an immersion vitrification case, don't take the CT scans as a strong indication. It has significantly less significance than in vitrification cases. Plenty of yellow areas in the CTs, say P19. How do you interpret them? Vessels, but expected to be carrying the perfusate unless occluded. So the yellow cutoff is slightly misleading because it's a hard cutoff, right? So in cases where you have a mixture, it's not as easy to interpret that, because it might just be that the concentration of the cryoprotective agent is just slightly lower, but it would already show up as yellow. We might in the future put a larger range there, where it's slowly going from green to yellow, just to make the visual representation, make it clearer what's going on. Here, yellow does not necessarily mean that it's significantly worse perfused. It's just a hard cutoff. That's the reason. And of course, partially it's vessels, plus partially these CT scans, they do a bit of a batching. So it's possible that there's like an area between in the brain that is not well perfused, let's say from the outside even, right? And then the part next to it would be yellow because of some batching. The rest is the primary reason, or the primary problem is that it's a hard cutoff. What is the current status of organ preservation? Who is currently conducting this research, and what are the success rates? So we would, when we have technology that we deem interesting for organ preservation, then we might do this ourselves. Otherwise, currently, we're not working specifically in organ preservation, even though, of course, some of our research would be very usable. Other than that, there's labs, also, of course, some of our collaboration partner labs that work on organ preservation as well. Right. In the recent report, there is a long delay between stabilization complete and start surgery. So adhesions does not explain it. Surgery start. Okay, remind me again. I think you mean I think 17, if I'm not mistaken. You would need, Boris. You need to remind me again which patient you meant. Either it was 19 or it was. I'll wait for this question because otherwise I need to scroll through this thing too much. Mission-driven company, what's the mission? The mission is to make cryopreservation work, right? Including, at some point, revival from cryopreservation, of course, that might be long-term in the future. Why does the cryoprotector take months to penetrate the brain? Shouldn't the brain be completely saturated within hours? No, cryoprotective agent is very, like a highly viscous solution that doesn't diffuse fast, so it takes a long time until it diffuses. How do you open the blood-brain barrier for not shrinking the brain? There's a range of different things that open the blood-brain barrier. The one that is currently being mostly researched is SDS, which is a detergent at very low concentrations. Theoretically, it could also be ultrasound in the future. It's an active research project, so the decision has not been made. The 3 boxes behind you at the beginning are cryopreserved patients. If you mean the 3 big, stainless steel, capsules, then those are doers, and yes, those house cryopreservation patients, also organs and brains and so on. I don't have Google Service on my phone. Would you consider adding support for other helps apps aside from Google Fit to integrate with the check-in apps? In theory, yes, but it's just a very complex thing to add on multiple things, so it would not be in the first releases. What's the reason behind the lengthy process of vitrification in animal preservation? I'm not 100% sure what the question is. Maybe elaborate, and I'm happy to come back to it. How's the relaunch of the Tomorrow.bio app progressing? It is progressing finally, so we'll wait for that, and hopefully we'll have some stuff to announce soon. Do you do some sort of small storage box that you can have few items stored in the facility until possible revival? Yes, if you signed up with us, you have a very small amount of storage. If you want more storage, we can make that work, but you need to reach out to us directly. Okay, Boris says all recent patients, yes. So the question is basically why there is delay between the start of between the end of the stabilization work and the start of surgery. Okay, now I get the question. So it's because due to the fact that we sometimes have or encounter in the surgical procedure, we encounter things like adhesions, we wait until we have reached 20 degrees core temperature. So basically, we want to cool down the body enough so that we have time for the surgery, right? And at that time, it's kind of a similar amount that you would have in an operation room, and yeah, that cooling down. So we wait until we reach around 20 degrees. If in the future we are consistently sure that we can do surgery in all cases we see faster, this temperature would go up. Right, then we would start, let's say, at 22 degrees or 24 degrees or 26 degrees. But once in a while, we still see like weird stuff where it's like a combination of adhesions and calcifications in the aorta and a lot of different things where they're not 100% confident. Right. Do you deal with currency fluctuations between US dollars, euros, and so on? If you mean for the long-term investment, then we would have an investment strategy that accounts for that. So have stocks, for example, denominated in different currencies, like potentially even have hold currencies ourselves, if that is the question. Could immune tolerance be affected by cellular damage caused by the cryopreservation process? Yes, I think it definitely could. Cryopreservation, a lot, if not everything, could in theory be affected, or I would even assume that it would be affected. But compared to doing all the repairs that need to be done and doing all the nanotechnology repairs that would need to be done in the future, I think these problems are probably, comparatively at least, not the biggest problems. So fingers crossed, at least for the time being, right? We are not working on these things directly because, again, there's a long list of other things that are, from a priority standpoint, as of today, still bigger problems. Who should I contact to become a standby volunteer in Italy? Just contact support@tomorrow.bio. Support@tomorrow.bio. We're more than happy to have people in the team and discuss and see who can get involved and so on. So just reach out. It turns out that the cryoprotector penetrates deep into the brain only after freezing when the brain is full of ice. Either I don't understand the question or that is not the case. So the cryoprotector agent also penetrates into the brain if it's not frozen. Do you still believe vitrification is a better bet than chemical fixation as a first option despite the advantages of fixation? Yes, in the case of real-world circumstances, right? In remote, wherever you are, right? At least I believe this until proven otherwise, right? So I would be great if there would be an organization that does that as a main procedure, and then we can compare how these cases go. For the time being, I would say that's probably still the case. In P20 delay is 50 minutes. In P19 delay is 19 minutes. The surgery itself is 30 minutes. Okay, sure. Doesn't sound like a question. So different cooling rates. Of course, different patients have different cooling rates, right? Some of them are it depends on the body weight significantly. It depends on different cooling methodologies, right? Even though cooling methodologies in our case, I think, did we have cases with different? No, I think we had all these cases have the same cooling methodology. The different delay times mostly would be body temperature. And of course, when we take over, right, we might also take over once there has already been some cooling in quotation marks. Just warm ischemia has happened. All right. Since we are running out of questions, if anybody wants to reach out or sign up, reach out to Tomorrow.bio or to support@Tomorrow.bio. Scan the QR code if you want to sign up. And of course, at any point, if any questions comes up down the line, and of course also for these case reports, just reach out by email, or if you speak some German, join us again on Wednesday, where we'll do the whole thing again in German. And now, without further ado, I'll check a last time if there's any questions, but I don't see any. So thank you so much, and talk to you soon.